And now, ladies and gentlemen, I've got sore throats a little bit. All right, but right now it's time for the anti-cancer. Wow, with Dr. Thanyanan Reungwetwattana, Division of Medical Oncology, Department of Internal Medicine from Ramatibadi Hospital. So today that she will share her experience on pharmacogenomics study of anti-cancer. Ladies and gentlemen, a big round of applause to welcome Dr. Thanyanan Reungwetwattana ค่ะ
Good afternoon, everyone. First of all, I would like to thank you, T-Cells, for your kind invitation to me to give a talk today, and just would like to share some of the experience with all of you. It's always hard to give a talk after lunch, right? So hopefully my talk in this 30 minutes will keep you awake for a while at least. Okay, all right. These 30 minutes, I will walk you to the pharmacogenetics in oncology. In this talk, I will separate the talk into two parts. The first part, I just would like to touch base a little bit about the pharmacogenomics for the efficacy and the toxicity screening for the anti-cancer drug. And the second part is very fascinating and is a hot issue in this era. So I would like to talk about the targeted therapy in cancer. So first of all, I would like to show you the survival rate of the cancer. So you can see here, this is for the whole type of the cancer. If the patients have the distant metastasis or the advanced cancer, the survival is pretty low, especially in the lung cancer, liver cancer, and some of the GI cancer that you can see the survival rate is just a single digits. So how we can improve this efficacy of the treatment, how we can help this group of the patients. So we'll talk about that later on. And this is the prevalence of the death rate in Thai population. The red line is the cancer death. So you can see here that now the cancer death is the number one or the first rank of the cause of death in Thai population, compared with the blue line, which is the accidents, and the green and the yellow line, which is the cardiovascular disease. So cancer is more important and it has lots of burden and problem in Thailand right now. And this is the leading cancer in Thailand. This is the data from the NCI. So it's categorized by gender. This is the cancer in male. Number one is liver and bile duct cancer, followed by lung cancer, and followed by colon and GI cancer. And this is for female. Of course, females' breast cancer is number one, followed by cervical cancer and liver and bile duct, because we have the HBV hepatitis, and also some of our population, especially in northern part and northeastern part of Thailand, they ate the the raw fish, which has the liver fluke that causes the bile duct cancer. And for female, colon cancer and lung cancer is pretty much the same. All right, so I'll start with the pharmacogenomics. So I believe that in the morning session you listened to Dr. Cholapat about this. So I would like to touch base on what is the involvement or the correlation of the pharmacogenomics with the cancer. So this is the definition. I believe you already know, so I'll pass this one. So the pharmacogenomics impact the pharmacokinetics and the pharmacodynamics, which is impact the efficacy and the toxicity of the cancer drug. And the pharmacogenomics are so valuable for optimize the drug therapy, including how to maximize the drug effectiveness and how to minimize the drug toxicity, including minimize the variability of the pharmacokinetics and the pharmacodynamics in each person. And of course, we would like to avoid the unnecessary treatment and minimize the toxicity of the drug. All right, this is the schema of the goal of the pharmacogenomics. So in the middle, you can see that all patients have the same diagnosis, but each patient have the different colors, right? The different color means like different pharmacogenomic profile, something like that. And of course, what we need is that we need to screen and select the right patient who will have the most benefits from our treatment and have the less toxicity. This is our goal. And the pharmacogenomic strategy is most relevant when number one, when the drug has a narrow therapeutic index. Number two, when the drug has a high degree of the inter-individual variability in response. And number three, when there is a little or no available methods to monitor the safety and efficacy of the treatment. And the last one, when that disease had a few alternative treatment options, and all of these things fit with the cancer, right? So that's why pharmacogenomics is have the very close correlation with the cancer treatment. Okay, I will give you just some of the example of the how we use or applying the pharmacogenomics in the cancer treatment. The very good example is 5-FU. So I believe everyone in this room know 5-FU, the 5-fluoropyrimidine, which is one of the anti-metabolic cancer drug. And we use this in a lot of cancer. It is a backbone treatment in the GI cancer, head and neck cancer. So we use it a lot in the global, and everyone knows it very well. And this drug has the toxicity, including hematologic toxicity like neutropenia, febrile neutropenia, thrombocytopenia, anemia, and including some of the gastrointestinal toxicity like diarrhea, mucositis. And some of the patients can have the skin toxicity, like shown in this picture, the hand-foot syndrome, which is like palmoplantar erythrodysesthesia. Some of the patients can happen like this, which is pretty severe, right? And we don't know which patient could happen or could have this toxicity. So how we choose or how we screen for this group of the patients. So this is the mechanism of action of the 5-FU. So 5-FU metabolism involved in many enzymes. For example, involved in the dihydropyrimidine dehydrogenase enzyme for the catabolic pathway, and also involved in the thymidylate synthase or TS in the anabolism pathway. So if the 5-FU inhibits the TS and leads to depletion of the DTTP and interfere with the DNA intersynthesis and the biosynthesis and repair, for the DPD is involved in like for the catabolism or inactivate the drug. So if the patient have the DPD enzyme deficiency, so that patient might have some of the alteration or polymorphism in the DPYD gene and might have severe toxicity. So, and if the patient have increased TS or something or polymorphism in the TS gene, so the patient will have the poor survival outcome. So this is one of the example of the 5-FU. And the other one is irinotecan, which is one of the topoisomerase chemotherapy. So this one also have the hematologic toxicity, including the cholinergic syndrome, such as like flushing, diarrhea, bradycardia, diaphoresis. So we don't know. Again, it's the same as the 5-FU. We don't know which patient could have the severe toxicity, especially the febrile neutropenia. This is the mechanism of action of the irinotecan. So the UGT1A1, which is the enzyme that change the active drug to the inactive drug. So this one is very important for the patient who's gonna receive the irinotecan. And if the patient have the UGT1A1 star 28 or star 6, the patient might decrease the expression of UGT1A1 protein and increase risk of the irinotecan toxicity, focusedly in the mainly in the patient who have the homozygous patients. And this is the paper that's just published early this year. This is the work from Dr. Chalamporn. I believe she is in this room. And Dr. Cholapat worked with our oncology unit that try to explore and study the polymorphism, the UGT1A1 star 28 and star 6 in colorectal cancer who received the irinotecan-based regimen. And what we found is the UGT1A1 diplotype if the patient have this diplotype, can have the more chance to have the neutropenia, even like grade 1 to 4, and especially grade 3 to 4, which is significantly happens. So now, that is just the example of the pharmacogenomics and the cancer. So now, I'm gonna walk you through the targeted therapy in the cancer, so which is more like very fascinating and very interesting in this era, as I told you. So it's more like we are in the war. It's a war on cancer. So, and even though the cancer cell is very small and we cannot see it, but is very, very strong. Like the Roman soldier here, like it's pretty same. This is a cancer cell, like in electron microscopy. So just imagine and keep you wake up. All right. And this is the hallmark of the cancer. So this is a diagram that brought by Dr. Hanahan. So for the first one, he wrote in the year 2000, and the second one is he wrote into 2011. In the past, we just know that the patient, the cancer has the acquired capability, the capability of the cancer cell just 6 capability, like involving in the apoptosis, the growth, and the proliferations. But now we know more. So now we know that the cancer have the 10 acquired capability as shown in these pictures. And we also know more that the cancer cells very complex. They have a lot of pathway, and now we can categorize the cancer pathway into the proliferation circuit, the viability circuit, or the motility circuit. And I would say that now we do have the drug that can hit with all of this acquired capability. And some of them is already approved and we already use in our clinic. But most of them is still in the clinical trial and in the clinical phase, like phase 1 and phase 2 trials. And this is the pictures that change the paradigm of the treatment. It is a somatic mutation of all cancers. And you can see here, the melanoma is the first and the cancer that have the highest somatic mutation, followed by lung cancer, GU cancer, and GI cancer. So for these pictures, leads us to think about the molecular targeted therapy, try to hit with some of the somatic mutations that we think it is the oncogenic driven mutation. And also, for this diagram, it also leads us to develop the immunotherapy, which is very hot issue in this era. So if the patients or some of the tumors here have the high number of the somatic mutation, that means that it might have the high number of neoantigens. And because of the highest number of the neoantigen, then the patient will respond to the immunotherapy very well. So that's why the immunotherapy that approved for the melanoma, number 1, and then now is already approved in lung cancer and some of the GU cancer. So So these pictures is like the doctors, it's like the oncologists in the past that we treat the patients with the chemotherapy and we hit everything. We hit with the cancer cells and we also hit with the normal cells. But now oncologists is more like the Superman or Supergirl. Should be Supergirl, right? So because we know the target, some of the target of the cancer, and then we try to hit with the right target. And if we hit with the right target, then we get a suggestion. But it's not very easy because what? Because of one of the cancer might have different and might have one more targeted or one more oncogenic-driven mutation. And if you find one of the mutation, one of the oncogenic-driven mutation, but it's hard to find the predictive biomarkers that help to select the patient who will have the most benefit with our targeted therapy, like this one. It's very difficult to find that one and couples of the targeted mutations in one cancer. So the definition of the targeted therapy is the drug that targets the pathway and the process and physiology which are uniquely disrupted in the cancer cell, like in hit with the receptor, hit with the gene, and angiogenesis, or hit with the immuno pathway in our body. So this is the ideally targeted therapy. That's the best one. The targets is to have in all cancer cells and not in normal. But I think it's hard to find this target. So the reality, so what we find right now is more targets in the cancer cells and just less in the normal cells. So nowadays we have this kind of the targeted therapy. All right. So I will show you how the targeted or how the targeted derive or stimulate the pathway, the cell signaling pathway. So this is the ligand that bind with the receptor, and then the receptor have the dimerization and have the autophosphorylation, and then they drive the cell proliferation, survival, angiogenesis, and the metastasis. This is the signaling pathway in cancer. So the receptor here could be like EGFR receptor, FGF receptor, IGF receptor, and etc. And the strategies that we try to inhibit the signaling pathway is number one, the tyrosine kinase inhibitor, which end up with the NEPs. So the NEPs will competitively bind with the ATP in the ATP binding pocket and try to inhibit the cell signaling pathway. That is number one. Number two, the monoclonal antibody that bind directly to the receptor and inhibit the downstream pathway. And number three, the monoclonal antibody that bind to the ligands and then inhibit the downstream pathway. This is a strategy that the scientists and oncologists try to develop the drug for treating the cancer. So let's guess, what is the first targeted therapy in our world? So it's not happened just like in these 10 years. So it happens like long time ago. So I believe everyone knows tamoxifen, right? So tamoxifen is the first molecular targeted therapy that's hit with the cellular receptor for the female sex hormone. So that is the one that we use for a long time. But the one that hit and established the concept of the targeted therapy is imatinib. Imatinib or Gleevec, which is we use to treat the CML, the chronic myeloid leukemia. So I remember, so this story is like very famous, and it's changed the paradigm of treatment like almost like 15 years ago. All right. The CML patients have the BCL-ABL translocation that drive the patient and drive the carcinogenesis of the CML. And for the drug, the imatinib that try to hit, and so I will have the pictures. So this is the Philadelphia chromosome that the patient who have the translocation in the chromosome 9 and 22, and then that drive the CML, and the imatinib competitively bind with the ATP in the ATP binding pocket and inhibits the tumor cell proliferation. And this is the landmark of the study that show if the patient who have the CML and have the translocation in chromosome 922, the imatinib induced the major cytogenetic response in 60% and complete hematologic response in 95%, which is very, very high. So that is the landmark study for the story of the CML. So the NIPS. The NIPS is the words that end up with the tyrosine kinase inhibitor, the small molecules. And generally, it is the oral tablet. And the side effect is vary. It depends on the pathway, depends on the target that they hit. So now today we have already 17 small molecules or the NIPS that approved for solid tumor. I will show you the table here. So you can see here, this is the cancer that we already have the NIPS, the small molecules, the TKI, tyrosine kinase inhibitor. So mostly it's happened in lung cancer. I will talk about lung cancer later. And so you can see here, colon cancer, melanoma, ovary, kidney cancer, all of these things already have the approved drug that's just the oral tablets. All right. The next one is the monoclonal antibodies. So usually it's IV, of course it's IV. And the side effect, again, it depends on the target and depends on the pathway that they going to hit. And this is the approved monoclonal antibodies for the solid tumors, colon, lung, GI, and some of the melanoma. All right, so now I will give you the example of the very good of the use of the targeted therapy. So it's lung cancer. So here, lung cancer is second rank of the highest of the somatic mutation. And the personalized medicine for the lung cancer depends on these things. So this is the molecular change alterations in the lung cancer. So some of the mutations it could happen and it's vary, depends on the ethnicity. For example, EGFR mutation. So in the Caucasian population, they might have just less than 20% of the EGFR mutation. But in our population, the Asian population, the prevalence is high up to like 50%. In Ramatipadi Hospital, the prevalence is around 50 to 55%. It's pretty high though. All right, and what makes it different? So you can see here, if we treat the patient, the lung cancer patient, stage 4, which the standard chemotherapy, the survival is just around like 8 to 10 months. But if the patient have the EGFR mutation or the targeted gene, and that we can hit with a TKI, then now the OS is increased more than 1.5 years. So some of my patients, the highest one is 6 or 7 years already. Just taking the pills, all right? And this is the key alterations pathway in the adenocarcinoma. So it's prominent in the RAS-RAF MAPK pathway and the mTOR pathway. That is for adenocarcinoma. And this is the molecular alterations that I summarized in one of the journal in 2013. And right now, we already have 3 approved drugs for the patient who have these oncogenic-driven mutations. But all of this mutation, we already have the pipeline, the drug that's in the pipeline in each pharmaceutical companies that now it has been tested in the early phase clinical study. And this is the potential target for the squamous cell carcinoma. I would say that the FGFR, PIK3CA, and the BRAF, these three have the high potential to be the targeted for the squamous cell carcinoma. And this is the pathway, the signaling pathway. And here is the EGFR receptor binding with the ligands and drive the downstream pathway, the RAS-RAF, MAPK pathway, and the mTOR pathway. All right. And EGFR mutation, we have common and uncommon mutation. The common mutation is exon 19 deletion and exon 21 L858R, which is a sensitive mutation for treating with the EGFR TKI. All right, and this is the phase 3 clinical study that proved of the concept that if the patient have the EGFR mutation and we treat with the EGFR TKI, the patient will have more benefit in terms of progression-free survival for the treatment. So you can see here that the PFS is double in the patient who received the TKI compared with the chemotherapy. But for the overall survival, it's pretty much the same. It's because of what? Let's guess. Because of when they do the phase 3 study, they allow the patient who failed the chemotherapy, allow the patient to cross over to receive the EGFR TKI after that. So that's why it's blind the OS benefits. All right, this is the example. This is a CT scan. This patient, this is my patient when I was in US. So this patient have 19 deletion. And just 2 months after I prescribed the EGFR TKI, you can see here, almost all the cancer cell is gone. And actually, the patient have the response of the treatment just like 2 or 3 weeks after taking the medications. This is one patient. And this is another patient. This lady is 85 years old. You can imagine that probably this patient could not receive any chemotherapy, right? But now, because she has a mutation here, this one is a common one, this one is uncommon one, and I just treat her with the EGFR TKI, and she responds very well. So currently, she's still taking the drug, so it's almost 2.5 years already, with a very good quality of life. And this group of the medication have the totally different side effect compared with the chemotherapy because EGFR is from the epidermal growth factor receptor. So mostly the toxicity is involved the epidermal, involved in the mucosa like rash, diarrhea, paronychia. Here, this could happen. This is a grade 3, the grade 3 rash. But you can see here this patient, even though she has a lot of rash, but she can smile because of this drug can help her and help her from disability. She cannot walk, and then just 1 month after taking the medication, she could walk. So that's why she smiled. But everything, and after that, after we treat her rash, and then she has a very very bright face, like before she's taking this medication. Mucositis could happen, and this is the one that we already treat, paronychia, dry eyes, keratitis, and the rash could happen in the scalp too. So this is like what we need to monitor and treat for the patients for the toxicity. And of course, when we use the drug, the resistance could happen. And the mechanism of the resistance for the patient who failed the first generation or second generation EGFR TKI is T790M mutation. So it's happened after the patient already failed the first treatment. And the other thing is the bypass track could happen to like HER2 amplification, PIK3CA mutation, BRAF, but the prevalence is not very high. The highest one is the T790M, which we found around 60% in Ramatipudi hospital. So now we are doing this study and try to explore what is the prevalence in our population. This is a population in the Asian populations, like 60%. And we already have the third generation EGFR TKI, which we hit with the T790M. And the first one, that's osimertinib, is already, the trend name is Tagrisso. is already approved in November last year. And this drug is hit with the T790M with the less attached or hit with the wild type EGFR. So that's why when the patient's taking this medication, the side effect is very, very low. But the cost of is very, very high. So it's around 500,000 baht per month. So the response rate for the patient who have the T790M is 60%, very, very high though. All right, and the progression-free survival is around 1 year. All right, and so now, believe it or not, the patient who already failed the third generation EGFR TKI already have the new mutation, which is like C797S. So we don't know much about this thing. It's just published in Nature last year. So, but what we know right now in the in vitro study, some of the patients who have this mutation probably could respond to the first or second generation EGFR TKI. So I feel much relieved with this news. Okay. All right, and now in the drug development, so now we already have the fourth generation EGFR TKI, and we already have the combination strategy combined with the monoclonal antibodies, combined with the immunotherapy in the futures. And the other thing, so it's just please give me more 5 minutes. So I just would like to show you a little bit more in lung cancer. So the next one is ALK rearrangement or fusion. So this one is in the chromosome number 2, and the prevalence you see here is not very high, it's 7%. In our hospital, it's around 10%. But the response is very well, it's just like the EGFR TKI story. So the response rate, even though in the first line treatment or the second line treatment, is around 60 to 70%. And this is the example. This is the 30 years old female. She just married, and then a couple months later, she was diagnosed with stage 4 lung cancer. So she has the ALK translocation, and I just treat her with one of the ALK inhibitor. Just couple days, this is a week, 2 weeks, so you can see here, it's clear in the left upper lung. This 1 month is more clear, and patients improve in terms of the clinical, in terms of the cough and dyspnea. And then just 1 month, I can discharge her from the hospital, and then now she can go back to work and go to like several couples rounds of honeymoons with her hubby. And now she's still taking ALK inhibitor, so it's like almost 3 years already, and with a very good quality of life. Okay, this is another one example. This is the cancer. Just 5 weeks after taking ALK inhibitor, so now this patient have complete remission, right? And here, this is the cancer, and it's gone, all right? And again, the same as the EGFR story, so acquired resistance could happen. And the L1196 mutation is the most mutation that we found in the acquired resistance. And we already have the second generation of the ALK inhibitor, ceritinib and alectinib, with the response rate very high, 70 to 80, 90%. All right, and this is the example. The cancer cell is gone for the ceritinib, and it's also penetrate to the brain very well. So now the cancer is gone. Here, it's gone. This is for alectinib. And what else? We also have the actionable lung cancer genetic aberration. So FGFR, RET, HER2, BRAF, PIK3CA, and ROS1. We already have the proposed medication that try to hit that one. For that, this one is ROS1. We also hit ROS1 with the crizotinib, which is also the ALK inhibitor, and the response rate is 60%. And now the drug is already approved for the patient who have ROS1 fusion gene. This is RET fusion gene, and we try to treat with the cabozantinib. And you can see the response is pretty good here. The tumor is shrinkage. This is just a proposed, okay? And the BRAF, we already have the BRAF inhibitor for treating the melanoma with the BRAF mutations. This patient have the lung cancer patients and have the BRAF mutation. And my supervisor in US tried to treat him with the Seboraf, and then the cancer is gone, right? And the Brafinib is also the BRAF inhibitor. The response rate is around 40%. Is not bad. It's very good. Okay, this is the response. The cancer is gone after taking 6 weeks of the Brafinib. All right. So breast cancer also have the same story. Everyone know HER2, right? So and already now we already have the HER2 inhibitors like trastuzumab, lapatinib, and pertuzumab, including the TDM1. So all of these drugs hit with the HER2 breast cancer and increase the survival, both in overall survival and progression-free survival for the patients. So all of this is the example of the targeted therapy and the pharmacogenomics for the cancer treatment. So, but everything is more like is high cost. So when we develop this targeted therapy, so the scientists and the oncologists should be very, very keen in terms of the clinical trial results, and we should have and identify the predictive biomarkers for choosing the patients to receive the targeted therapy. And just would like to end with the research. So the cancer is the whole thing, and I think it's it's a burden disease in Thailand right now, and it's a very important problem in Thailand. So we need to fill this gap, even like in prevention and in the treatment. We start from the bench work and then spread out to the prevention and the treatment. And everything is involved in the pharmacogenomics. And in our hospital, Ramathibodi Cancer Research, so now we already have the project that try to explore for the prevention. Like for this study, we cooperate with the EGAT. EGAT is Electricity Generating Authority of Thailand. Is a population here, and we have like the long-term follow-up with this population. And Ramathibodi Epidemiology Center and Ramathibodi Cancer Center, and we try to explore these population-based studies. Explore what is the good things, what is the good drug for prevent our population from cancer. And the other things that we also have, and we work with Professor Vasan, this is the cooperation between the medical genomics biobanks and Ramathibodi Cancer Center. We try to study and explore the molecular alterations in Thai population, especially we're studying now from lung cancer. And we're trying to develop the diagnostic test for lung cancer, both in the tissue and both in the liquid biopsy. And we also have the ECDD, which is the Excellent Center for Drug Discovery, that we have the cooperation with T cells. We have the cooperation with the Faculty of Science, Mahidol University, and Ramathibodi Hospital. The concept is we try to develop and try to screen the high throughput from our compound and try to find the targeted, the molecular alterations in our population, and work and cooperate with the ECDD to develop the drug. And probably we can change the program of treatment in our population. So, and the goal is Thailand as a base for the drug innovator and manufacturer to help our population, because the targeted therapy is now very, very expensive. And everyone should work together to help the patients and improve their quality of life. Thank you for your attention.
Thank you very much. And anyone has any question? Any question? All right. Ladies and gentlemen, once again, give a big round of applause for our Professor Dr. Thanyanan Reungwetwattana, Division of Medical Oncology, Department of Internal Medicine from Ramathibodi Hospital. And this is very interesting update on the pharmacogenomic study of the entire cancer from her, really, indeed. Thank you very much. Wow. And now our Professor Wasan is already present her our token of appreciation. Well, thank you that she is coming to join us today. And right now, okay, so before we take a break, all right, so it's our greatest honor to have Assistant Professor Thapong Tempak with us today too. Ladies and gentlemen, once again, a big round of applause. Thank you very much for sharing your experience, and your knowledge is really so fruitful, become a really useful information for us all to develop our treatment for our patients. And we also have 3 more sessions waiting for you, so please stay tuned, okay? All right, but right now we will take a break for around 20 minutes. So we open for every one of you who would like to sign for the education credits. Please visit at the registration point. And the booth in front of the room is waiting for you. So please enjoy 20 minutes. Thank you.